Assalamu alaikum wa rahmatullah. Do you hear me?
عليكم السلام ورحمة الله. Yes, we hear you.
عليكم السلام ورحمة الله وبركاته. أيوة الصوت واضح.
Assalamu alaikum wa rahmatullahi wa barakatuh. I'm going to start this Zoom presentation with tips and tricks for nuclear cardiac imaging. And we all know that the heart is a powerful muscle, consists of two. The heart is a powerful muscle that consists of two pumps side by side. And we have a lot of diagnostic modalities for heart disease. We are going to concentrate for a while on the radionuclide imaging. So let us start. The history of nuclear cardiology is a long history. Thallium 201 was used in 1971, and myocardial metabolic imaging was used in the last 10 years. What do we do when we report on any nuclear cardiology report or interpretation? When we see any defect, we should locate that defect. We should say what is the extent of the defect, the severity. Is it reversible or fixed, quantitative or semi-quantitative analysis? So whenever we see any defect on nuclear imaging, we should specify those criteria. Other information are important to include the phenomena of transient ischemic dilatation, which is a marker of triple vessel disease or ischemia, and also lung uptake. Usually in nuclear cardiology, sometimes we find extra cardiac findings like masses, like a breast mass or a liver mass or a gastric mass, and that should be included in our report. So who are the types of patients who come to the nuclear cardiology lab? We have two types of patients. Naive patients who are not known before to be cardiac, or known patients with cardiac disease and they are tested for their stability on cardiac medication. What are we actually detecting in nuclear cardiology? So we are detecting in nuclear cardiology, we are looking first for ischemia, 2 for viability, and 3 to assess LV volumes or ejection fraction before or after chemotherapy. So these are 3 main indications why we are doing the nuclear cardiology test. The first important question is ischemia, present or not, and if it is present, how much? Viability by doing FDG, fluorodeoxyglucose uptake. And 3, to assess the LV volumes or ejection fraction before or after chemotherapy. So we have a conventional cardiac physical stress test. As you can see on this picture, it is a bicycle. And we have pharmacological stress test, which we use dibaridamol or adenosine, all or riga-adenosine. So the pharmacological stress test we can use, or the pharmacological stressor, can be dipyridamole or adenosine or dobutamine. Recently, we are using Lexiscan or riga-adenosine. Riga-adenosine or Lexiscan is also a vasodilator. So adenosine is a vasodilator, dipyridamole is a vasodilator, but dobutamine is a chronotropic drug that increases the heart rate. The other pharmacological agents, they don't increase the heart rate, but they can cause vasodilatation, and they can cause side effects like abdominal pain or epigastric pain. And we usually advise the patient not to drink tea or coffee for 24 hours before the procedure. So let us take the examples of patients who are sent for nuclear cardiology lab. Who are the types of patients who are sent for a nuclear cardiology test? The first type of patient is a patient who visited the emergency room with chest pain, and his troponin or ECG workup was negative. So he was sent home, but he was requested to come back to do the nuclear cardiology test. 2 is a pre-operative or a pre-transplant patient. It has been now standard in our center to send patients for any major operation or any transplant, liver or kidney, for a heart transplant. Sorry, kidney or liver transplant. Usually, these are the types of transplant we are doing. And these are the type of patients we are doing the nuclear cardiology test for them. So these are the types of patients we are doing the nuclear cardiology test for them. So this is the second category. The third category of patients who are sent for a nuclear cardiology lab are patients who went to the cath lab, and the doctor in the cath lab found a borderline lesion that he wanted a physiological assessment of it. Yeah, he found like a 60 to 70% LAD lesion, and he would like to see if there is inducible ischemia by a nuclear cardiology lab. Sometimes also, before you perform PCI or CABG, we know now that there are 2 important landmark trials for ischemia has been published. Last year, ischemia trial was published, and 10 years ago, another trial was published about stable angina. So by doing nuclear cardiology testing, you are quantifying the amount of ischemia. So if the amount of ischemia is huge and it is associated with chest pain, as in the ischemia trial, intervention is warranted or is indicated. If the amount of ischemia is mild to moderate, then the patient can be treated medically. That was shown in the Courage trial, which was published 10 years ago. Recently, the ischemia trial, and in the ischemia trial, even high burden of ischemia without appreciable chest pain was not associated with difference between medical therapy and amount or intervention. So let us take this example of a 61-year-old male who's known case of type 2 diabetes, and he came to the ER with such ECG. The ECG, as you can appreciate, the patient is a normal sinus rhythm. It is a standard leads, the speed of 25 millimeters per second. and they are appreciable Q waves, deep Q waves in V2, V3, V4, and there is small R in V5 and also smaller R in V6, but there is still some ST elevation, and probably there is some ST elevation in lead 1. So this is a patient with late presentation, anterior or anterior STEMI or anterolateral STEMI or anterolateral MI, and he's already chest pain free. So what shall we do? We will do an echo to see how is his LV function, if there is any LV clot, because we know that anterior MI is associated more with clots, apical clots, and echo sometimes does not really visualize the apex very well. If you do an MRI following anterior STEMI, you might find a small clot up to 60% of all anterior STEMI. Anyhow, we did an echo, ejection fraction is as expected, 35 to 40%, akinetic LAD area, no significant valvular pathology. So what shall we do next after the echo? We did cath, but cath is done on a semi-elective basis. This is a catheter, probably a radial catheter approach, short left main, circumflex artery, and it is diseased in the groove. And this is the LAD proximally, there is mild disease. And after a good size second septal, there is complete occlusion of the left anterior descending artery. This is a diagonal branch, which is of a good size, and it is also proximal disease. So we know that according to the guidelines, if the patient is late presentation MI and he came after 48 hours, we should not do BCI. Angiography is indicated, but BCI by putting a stent is not indicated because we don't know about the area, whether it is ischemic or viable. So the RCA is shown on this picture. It is a huge dominant RCA, and probably there is some collaterals to the LAD from the RCA. So what did our CAS consultant ask us to do? He asked us to do a viability testing. What do we do in viability testing? We do rest rubidium scan. So we inject the patient with rubidium to see the perfusion of rubidium during stress, and we can easily appreciate there is a defect involving the mid-anterior wall, distal anterior wall, apex and inferior apex. And at the same time, we will inject the patient with radioactive glucose, or fluorodeoxyglucose. And the glucose uptake indicates that the cells are active or metabolically active. And what we look for is a mismatch between the metabolism and the perfusion. You can appreciate here, there is FDG CTAC and there is rest CTAC. So we are comparing the fluorodeoxyglucose uptake to the rest rubidium, and we can appreciate very well that there is very good uptake of glucose in the mid-anterior wall and in the distal anterior wall. There is actually hyperactive uptake of glucose in the distal anterior wall, and this indicates more ischemia because the myocardial cells, which are dependent on glucose for their energy substrate, they are very hungry for glucose when they are even ischemic. And this area here is papillary muscle, you can see it. So this patient has very viable LAD area. If you remember in the angiogram, he has collaterals from RCA to the LAD. So this is a patient whom you will send for PCI and stenting, and the cardiologist or the cath lab consultant will be happy because it is expected that the patient will benefit from the intervention. Let us take a second case. of a 56 years old male.
Sorry,
with
Dr. Ihab, we have a
diabetes,
question.
hypertension,
Dr. Ihab,
cerebrovascular accident, recovered. He has occasional chest pain, and he came to the ER. And in the ER, usually our setup in our ER, and probably this is the setup everywhere else, is that we do at least 2 sets of cardiac enzymes, peripheral troponin I or troponin T, and also ECGs twice. And then we take good history, physical exam, and we rule out heart failure or acute coronary syndrome. If these are negative, then the patient will be given a outpatient appointment to get a nuclear stress test or any further evaluation, echo or otherwise. So this patient was sent for a nuclear cardiology scan by stress rest rubidium. The material we use, nuclear material we use, is rubidium, which has a half-life of only 2 minutes. And the pharmacological stressor we use is Lexiscan or rigadenosone, which is a vasodilator. Here on our left side, you will find stress CTAC, rest CTAC, stress CTAC, rest CTAC. And on the upper left, you will find stress CTAC 120 and rest C static 120. 120 is 120 seconds or 2 minutes. We are imaging the heart 2 minutes after we inject the rubidium. So we are injecting the rubidium and we are taking photos or images of the heart during stress, and we compare the same areas of the heart to during rest. And we can appreciate the donut. We should have a shape of donut, complete donut, without any defect. And then we should have a horizontal view like this. And also we should have a vertical view at the bottom. You can easily appreciate that at position 3 in the clock, or in the lateral part, or the basal lateral part, there is significant amount of ischemia. In addition to that, if you see the cavity of the left ventricle during stress in the first image, and you compare it to the cavity of the left ventricle during rest, you will find that the cavity is actually bigger. So there is appreciable TID. You look here and you find the TID of 1.22. Usually the TID is 1. The cavity of the left ventricle should be equal during stress and rest. And if it is bigger during stress, that indicates severe cerebral disease or very proximal LAD disease. This patient had ischemia on the lateral wall or a circumflex artery, which is unlikely that it produces the TID. So it means that the patient has a triple vessel disease, and the circumflex artery maybe is the culprit for the presentation with chest pain. What shall we be doing next? Nuclear imaging is a gatekeeper for cath, so the patient will undergo cath. Before we go to the cath, we can see that the calcium score is only 12. So sometimes in younger people, the calcium score might not be high to exclude coronary artery disease. So the patient went for cath, and as we expected, this is the circumflex artery, which is not dominant, but you can see there is 2 significant lesions in the circumflex artery, and probably there is also significant lesion in the LAD. And you can see that there is a significant lesion in the LAD, mid-LAD, with the diagonal complex lesion, and there is another lesion. And the RCA is almost free of disease. The RCA is a big artery, so there is proximal and mid-LAD disease, and there is significant circumflex disease. So the patient has triple or at least 2 vessel disease, and the patient went for coronary artery bypass graft surgery. So let us take another example of a 67-year-old male with recent anterior MI. He came from another hospital and he was sent for us. So this is a static image of the echo. You can see that the anterior wall is like scarred tissue here. And this is the inferior posterior region, mitral valve, aortic valve. We did not have a clip. So the same patient actually had an echo, and his echo is showing very poor LV function with probably scarred anterior wall. But you cannot make sure with echo alone. Sometimes you need another modality like MRI or nuclear or so. So what happened to the patient? He was cast, and you can see that in his cath, first the RCA is occluded. We can see the RCA from the left injection. The circumflex and the LAD is diffusely diseased. The catheter lumen is only 2 millimeters or diameter, and you can see that all the vessel calibers are less than 2 millimeters. So the patient has severe diffuse 3-vessel disease, and the patient had multiple arrests in the MCICU because of arrhythmia, VT, VF, and he was seen by the electrophysiology, and they labeled the type of ischemia, the type of ventricular arrhythmia as ischemic in origin. But the cardiac surgeon refused to take this patient to the OR unless we proved for them that this patient has a viable myocardium. The echo was not really rewarding. So what we did also, again, we sent the patient for FDJ viability. Here we put the FDJ down and we put the rest rubidium up. So fluorodeoxyglucose, we inject radioactive glucose to see if there is good uptake of myocardium of glucose, because glucose is a marker of living or ischemic myocardial cells. So when we injected the rest rubidium, there is a big defect in the septal and distal anterior and inferior wall. But when we inject the fluorodeoxyglucose, there is good uptake. The whole donut shape of the heart has very good uptake of fluorodeoxyglucose, and that indicates that this patient has a very viable, very ischemic myocardium, and he deserves or he needs revascularization. At least this will help his arrhythmia to stop, and it will make his LV function hopefully recover. The data for viability is old dated. We don't have actually any new data about viability and revascularization on a large scale viability. The only published data was the STITCH trial, and the viability testing in the STITCH trial was dependent on thallium, not rubidium or fluorodeoxyglucose, and dobutamine stress echo. So the data, the bulk of the data on viability is all dated. But the new data might come soon in the future, and it might give credit to the new nuclear material like rubidium or fluorodeoxyglucose. So this patient went for revascularization. And let us take about the Braun images when we are doing technetium. Sometimes we do technetium, and it is important to look for an artifact in the inferior wall. So you can see how is the quality of images when we use technetium. Technetium is different from rubidium. It will not produce very crispy images like we see in rubidium. So this material here used was technetium. If we want to read it, we can easily appreciate that there is an anterior defect seen on the anterior wall. This is stress and this is rest. So there is ischemia of the anterior wall and the lateral wall, and there is no ischemia or anything in the inferior wall. Usually when we did a Brown image, this is a Brown image and this is a stress image. The Brown is a stress. So the Brown is during stress, we ask the patient to lie on his abdomen. So when we ask the patient to lie on his abdomen during stress by Brown, usually we look for inferior defect to clear. But in this particular patient, we found that even anterior defect cleared, and the Brown stress images is very normal and very good. So that indicates the importance of doing a full exam by technetium. In America, they don't do Brown images in most of the centers because it will be time consuming. After you finish obtaining the imaging during stress, you ask the patient to do another set of image while the patient is on his abdomen. So the patient anyhow continued to have chest pain, and he came to the ER several times, and eventually he had CAS. CAS showed a normal corona. Thank you very much for this, and I will just take few minutes to discuss with you the I would like just to discuss with you
رحاب السلام عليكم. رحاب
سعد
Assalamu alaikum. This images
وعليك ترحتي ذاته والله حاجه بتاع بقول
ما سمع الصوت
بتشوف وخاطر جايتها
لا ما تعمل ساعة منتظرة ودقيقة
والله لكن
بدأ
بتشوف
Aha, terus ada terus sama
لبيك
saya.
اللهم لبيك اللهم لبيك لبيك لا شريك لك لبيك إن الحمد والنعمة لك
ولا العامل حيدي ولا عامل شيء. لما تكتشف الصوت ترى
بلاش وصل
ما هنا الصوت.
تسقط الصوت والي تلقي الميكروفون سالم موسى
سألت خليها حاجة ذكرت الميتنج.
السلام عليكم دكتور ابتسام.
الو
ممكن تكفي الميكروفون حقك لأن احنا سامعينك وشايفينك هسه.
خلاص كويس. بس عشان مش هتفتح الكاميرا.
I think the
حط السماعة.
فتح الكاميرا هذا بطاقة
يلا وصل.
sorry, I think I have a problem with the loading of the videos, but I will just give you important thing about section.
وصل وصل وصل.
الكاميرا
هنشوف فيديو بعدين نشوف فيديو. شاهون. من الرياضة الميتنج.
أكثر شو؟
أكثر الكاميرا والصوت اللاتين. سامع. كده. كده. دقيقة.
I have just
ابتسام لو
few
سمحت
questions
الكاميرا
about
بتاعتك شغالة.
الكاميرا
dissection,
شغالة يا تعال.
aortic dissection. It is
فيديو
important
فيديو اطفي الفيديو لو
talk
سمحتي
about
دكتور
it.
ابتسام.
يلا الكاميرا شغالة.
So the history of aortic dissection is long. I'm not going to go through the history of aortic dissection, but let us take a few questions. What is usually the pathogenesis of aortic dissection? Is the intimal teeth.
انتهت الحمراء.
The pathogenesis of aortic dissection is actually the intimal tear, and sometimes it could be the intramural hemorrhage due to the rupture of vasa vasorum in a defective medium. What are the underlying issues associated with dissection? The most important thing is cystic medial necrosis. And cystic medial necrosis can be present even in patients without dissection. And aortic dissection notoriously has been associated with Marfan syndrome, Ehlers-Danlos syndrome, aortic dilatation, and thoracic abdominal or familiar, and also has been associated with bicuspid aortic valve, Quark, or Turner syndrome. Actually, patients with Turner syndrome, they die because of dissection. For the risk factor, I am going to dissect two risk factors, Marfan syndrome and hypertension. So Marfan syndrome is present in up to 10% of all ascending aortic dissection, and the prevalence in the population is only 0.02%. If you look to hypertension, hypertension is present in up to 90% of all dissection, and the prevalence, we know that the prevalence of hypertension is at least 40% among adults. So this is important to know. This is the Marfan syndrome. Marfan syndrome has important features to consider. They have very long arms, fingers, and toes. They could have big on breast or severe pectus carinatum. Sometimes they need surgery for their chest deformity or scoliosis, and also for their dislocated lens and family history of Marfan syndrome. How you can diagnose Marfan syndrome? It is not a straightforward diagnosis. You need to go through certain pathway to diagnose. So you should have a major criteria to be satisfied, plus or minus minor criteria. The major criteria are dilatation of the aorta and aortic dissection when you talk about the cardiovascular system. And when you talk about the cardiovascular system, there are other minor criteria like mitral valve prolapse, dilatation of a main pulmonary artery, or premature mitral annular calcification below the age of 40. And you should have, for cardiovascular system involvement, you should have at least one minor criteria, one major criteria. In the ocular system, you have only one major criteria. All in all, in the ocular system, you have ectopia lentis. So if the patient has ectopia lentis, he satisfies a major criteria. And let us go to the musculoskeletal. You will be surprised that how is the musculoskeletal major criteria has been divided. So you should have at least 4 of the following: pectus carinatum or pectus excavatum requiring surgery, or reduced upper to lower segment ratio, or wrist and thumb signs, or scoliosis more than 20, reduced extension at elbow, medial displacement of the medial malleolus causing like a flat foot, or protrusio acetabuli of any degree. I will show you a picture now. So this is pes planus or long foot, and it is pes planus of patient with Marfan syndrome. And this is a patient with long fingers and with the thumb thigh. And this is a family of a patient with Marfan syndrome. This is a patient with Marfan syndrome who underwent surgery. And this is another lady affected with Marfan syndrome. So in order to prolong the life of patient with Marfan syndrome, we should have correct diagnosis, medical management, usually with beta blockers and ARBs, and surgical repair. Clinical evaluation is important. You should have an eye ophthalmologist who should look for lentis. You should have a detailed history, and you should have a rheumatologist looking for the musculoskeletal diagnosis. Very important is to avoid strenuous exercise and to use beta blockers. And you need to be on alert to replace the aortic valve when it is, the recent guidelines call for 4.5 centimeters to consider replacing or doing the surgery for aortic valve. Sorry, for aorta patient with Marfan syndrome. The etiology of dissection is intimal tear or hemorrhage or intramural hematoma or penetrating atherosclerotic ulcer. So these are the 4 types of aortic dissection. This is important to remember because when you do the CT scan, you need to look for these important findings. Of course, we have 2 anatomical classification, Michael D. Behe and Stanford, and we use Stanford classification for aortic dissection. We don't use Michael D. Behe. And we have also time dissection. If the patient presented within 2 weeks,
دكتور إيهاب السلام عليكم. الو دكتور إيهاب.
So just to continue dissection, ascending dissection account for 3/4 of dissection, and descending dissection account for 1/3 of dissection. And for ascending dissection, usually the first start or the first tier is within a few centimeters of the aortic valve, and in 50% of cases of dissection of ascending, it involves the iliacs. The descending dissection, which is 1/3 of all dissection, can have variable extension. The completion of dissection can include tamponade or mediastinal or pleural rupture, or they can cause acute aortic regurg, which complicate 50% of all ascending dissection. This is how is aortic acute aortic regurgitation is produced by dissection and by the tearing forces. And this is another view of the aortic valve damage. And sometimes you can get branches of aorta being involved with dissection. So in a patient with dissection, he could present with a stroke if the carotid artery are dissected, paraplegia if the spinal artery is involved, hypertension, renal failure, visceral ischemia if the bowel vessels has been involved, and inferior MI or any type of MI, myocardial infarction can also develop. So it is important to see how is dissection can be extending or can present. So the location of ascending dissection, if there is ascending aorta dissection, the site of rupture is intrapericardial, and this can lead to tamponade, but the left pleural effusion is involved in only 6% of cases. If the arch of the aorta is dissected, it will only rupture within the pericardial cavity within 35% of cases. But the left pleura can be involved in up to 1/3 of them. Only the descending dissection is very rare to have tamponade or to have a rupture within the cavity of the heart, but the left pleura is involved in 44%. We all speak about left pleura in dissection. We don't speak about right pleura because it is the left pleura which is involved with the dissection. We don't know actually how much dissection is present or the prevalence of dissection, but we know by autopsy that at least 0.2% of all autopsies they show some sign of dissection. Males are commoner than females. Ascending dissection involves the age of 50 to 55. Descending dissection involves the age of 60 to 70. If there is dissection below the age of 40, look for 3 causes, 3 underlying causes: Marfan syndrome, pregnancy, or aortic valve disease like bicuspid or coarctation. So if you are called or if you suspect dissection below the age of 40, you should look for Marfan syndrome or pregnancy. Pregnancy may be more commoner than both Marfan's and aortic valve disease or bicuspid aortic valve. And don't forget that even doing cardiac catheterization iatrogenically can cause dissection. People who do cardiac catheterization on diagnostic purpose or for therapeutic purpose can cause the intimal tear and they can cause dissection. What are, let us just take few MCQ about thoracic aortic aneurysm. All are chest X-ray findings in thoracic aortic aneurysm except widening of the mediastinal shadow, displacement or compression of the trachea, displacement or compression of the left main stem bronchus, or displacement or compression of the right main stem bronchus. So out of these 4 statements, 3 statements are correct, but there is a statement which is false and it is a correct answer. And remember, when we talked about the dissection in a while, we did not speak about the right side. So involvement or compression of the right main stem bronchus is not found in patients with aortic aneurysm, thoracic or dissection. So what are the chest X-ray findings? You can read it in a little bit. So it is wide mediastinum is the chest X-ray finding typically, and also the calcium sign if there is intimal displacement. This in elderly people more than 5 millimeters, or there is altered mediastinal or aortic root, or opacification of the AB window, and also left apical pleural cap. And pleural effusion, if you want to look for it, look more on the left side, more than the right. Remember, trachea or esophagus can be dilated. So these are the chest X-ray findings of acute aortic syndrome. I am not sure whether you are getting the screen or the microphone. Are you hearing me now?
We hear you. We just got the screen. It seems that you can't hear us.
So these are the dissection facts. Let us talk about this maybe, and probably this might be the last slide we share with you. All are true about abdominal aortic aneurysm except abdominal. So we are talking about abdominal aortic aneurysm. Occur more frequently in males than females. 90% are atherosclerotic in origin. Atherosclerotic aneurysm are more common in suprarenal abdominal aorta, and the 5-year risk of rupture is 40% if the size is more than 5 centimeters. What is the correct statement or the false statement, which is a correct answer, is that atherosclerotic aneurysm are more common in suprarenal. It is more common in infrarenal. Let us take maybe the most common site of initiation. I think this MCQ is very crucial to know. So where is the most common site of initiation of dissection? Is it the right lateral wall of ascending aorta near the origin of the right coronary artery? Or is it the left lateral wall of ascending aorta? Or is it the infrarenal descending aorta or suprarenal abdominal aorta? And the correct statement for this is the right lateral wall of the ascending aorta near the origin of the right coronary artery. Thank you very much. And I am sorry for the technical failures. And thank you very much. This video will be uploaded on YouTube.
لا لا اللي عمل لك